Thanks, Alison. It's my privilege to be chairman of the first session of the first and the best Ethicon Cardiac Symposium. And we're probably talking about one of the most important operations we do on the aortic valve. I've just got a few slides to introduce it. And I think the aortic valve surgery is our most important operation as surgeons because it's one of the sort of more simple, reproducible, sort of safe operations. And certainly for aortic stenosis, it's the one area where there's no real effective medical management. So we have the only real effective therapy as surgeons. In the Western world, with the increasing population, it's the area with aortic stenosis of an increasing incidence. And we also, more importantly, know that if you don't treat severe symptomatic aortic stenosis, the prognosis is probably the poorest for all the patients worldwide on cardiac surgical waiting lists. The group that does worse is the group with symptomatic severe aortic stenosis. So for those reasons, I think this morning it is really important. If you look at sort of relatively recently, my training experience of the aortic valve, there was one sort of option, which was simple replacement, and there was one further choice, mechanical or bioprosthesis. And the operation had three major principles, which we thought would never change, really. A median stenotomy to get at the valve, the need for cardiopulmonary bypass, and the need to suture in some sort of prosthesis. And all those three things in the last sort of 15 years have changed, as we'll find out today. And the other thing that's changed is the postgraduate education, much more emphasis on that, so that the things we learned as trainees, there were some surgeons that I had the pleasure or not of being trained by, whose practice was the same as the practice that they had on day one as being a consultant. And I think in our generation that's completely changed. There's more emphasis on postgraduate education, which is vital. So now we have an expanding range of options for the aortic valve and an expanding range of opportunities to learn about those options. So I think it's good that the aortic valve was chosen as the first session for this first cardiac symposium. And we're going to start with a cardiologist, with Dr. Rachel Janes from Royal Sussex County Hospital, who's got the hardest job today, I think, of starting first and making the AHA-ACCC 2014 guidelines really exciting. So without further ado, I give you Rachel.
I think I'm wired up. I was going to thank you, David, but I'm not sure I am now. Good morning, everyone. Thank you to the organisers for inviting me to speak to you. Now, I've been tasked to talk about the guidelines, but within the ACC-AHA document, there's clearly a lot more than just guidelines, and I'm going to touch on some of those this afternoon after the mitral valve talk, where there's a little bit more time, so things like the new classification of valve disease and things like the role of heart valve teams. So going straight on with this, I'm going to clearly talk to you about the guidelines and where necessary just draw where they have changed from the last batch back in 2006 and where they slightly differ with the 2012 European guidelines. I'm going to just touch on the increasing of mean gradients for assessing AS and this increased emphasis on exercise testing in aortic stenosis. The rather tricky area, which I think we're going to see more of low flow, low gradient, but preserved ejection fraction aortic stenosis, and the use of natriuretic peptides in aortic stenosis for guiding management, and then just a single slide on TAVI, and then for aortic regurgitation, something that I'm bang on and on about, which is the business of importance of indexing for body surface area when it comes to assessing the ventricle in aortic regurgitation. So as David said, aortic stenosis, it's common and it is lethal. And a lot of the work that we have regarding the impact of this condition is old, it's 20 years. But in two recent studies with patients with at least moderate aortic stenosis, so those with a valve area below 1.5 centimetres squared, although we worry, these were the ones below 1, if we look, the incidence of sudden cardiac death, which is what people worry about, is 1.6%. But of course, within there also increased risk of cardiovascular death. And this was a short, medium follow-up, a year and a half. And the importance of symptoms, which dramatically changes the onset of symptoms, the natural history of this condition. And this is Blaise Carabello's work 20 years ago now. And the thing that a lot of the registrars will worry about is exertional syncope. And actually in clinic, that's pretty rare to have a patient give you that. But it's the really lethal one is developing symptoms of heart failure. And once you have symptoms with aortic stenosis, your mortality rate is around 2% per month. And also, if we then serve you up patients who we've allowed to get particularly symptomatic, they also have an increased perioperative risk too. And within the risk of things like death, what it doesn't also tell you about is morbidity. And we've all had patients, they seem quite well, and I've seen them on my Friday clinic, and then there's a phone call from ITU, and they've come in frank pulmonary edema, and they have a long stay, and then they're served up with an inpatient operation, not in the best. So no real feeling for the increased sort of morbidity with the situation. Now, despite how common it is, the optimal timing for aortic valve replacement is still controversial, and we do have a lack of data with things like determinants of progression, and most of the recommendations within any of the European or American guidelines are B and C level evidence, very few randomized trials, and we're certainly overdue. So what are the indications? So class 1 for aortic stenosis, which the Americans define as a peak velocity of 4 meters per second. That's a gradient of 64 or a mean gradient of 40. So it's about symptoms. And here, not just at rest, but on exercise testing. And the role of exercise testing has moved from a 2B classification 10 years ago now to a class 1. So if you can demonstrate symptoms on exercise testing, you're in class 1. If you have an ejection fraction below 50, or clearly if you're undergoing another cardiac operation with severe AS, that's would be class 1. With 2A, which was previously a 2B classification, this concept of the very severe aortic stenosis, so gradients in excess of 100 or a mean gradient greater than 60, and that really is absolutely sort of stonking aortic stenosis. Asymptomatic patients who are of low surgical risk. Now, this is within this business of asymptomatic, very severe aortic stenosis is within the European guidelines, but they go a little bit higher, so they want a peak velocity of greater than 5.5. Or if you can show that you have a progressive increase in your velocity each year, so they've said more than 0.3 meters per second. So what if you're between, if you have a gradient between sort of 64 and 100, and you are apparently asymptomatic, what should we be doing? Well, if we treadmill the patients and they either have a reduction in their exercise tolerance, which is not defined anymore, and that's pretty loose, isn't it, for some of these that are elderly patients, but also a drop in your blood pressure. That's a 2A indication, so you can see exercise very important. The other 2A indications are the low flow, low gradient aortic stenosis, where the ventricle is impaired and you have a heavy calcified valve with a low valve area and you have a low gradient. And that's where a dobutamine stress echo comes in, and they're really rewarding to do, because usually within a few minutes of doing the test, you can see the patients who pick up their contractile reserve and the valve area remains unchanged, and yet they get a brisk increase in their gradient, and it's usually very obvious within the first few minutes. This is a difficult concept, and I'm going to just have a slide about this, which is low flow, low gradient, but apparently preserved ejection fraction. So patients who have a small valve area, whose EF is preserved, but who have a low stroke volume. So the cutoff is below 35 mils per meter squared. Just the rest of the classifications, the other 2A would be if you've got moderate AS and you're undergoing cardiac surgery, and a 2B for the Americans would be if you are asymptomatic but you can show that you are increasing your velocity progressively. So that's slightly different from the Europeans where it's a 2A. Now, within the European guidelines, another reason to operate would be, within 2B, would be an increase in natriuretic peptide levels. I'm going to come on to that. or the Europeans rather like stress echo, exercise echo. So if you can demonstrate that your mean pressure gradient increases above 20 with exercise, then that's a mean gradient, not a peak. And also, they're rather like the excessive LVH in the absence of hypertension. And I don't think we're very good at cardiologists about thinking about a referral on these guidelines, but in fact, work fairly recently showed that if you have exuberant, excessive LVH with aortic stenosis, that you have double the morbidity, but also the mortality post-AVR than patients who don't. Class 3, there isn't a surgical class 3 issue, but it's just don't prescribe statins. And we know that the randomized trials from statins for aortic stenosis were all negative, although they were started when patients had established aortic stenosis. So it would be interesting to see if the prevalence of calcific aortic stenosis changes with the sort of all the middle-aged population that we have out on statins, or whether this will translate into a change as they age. Previously, a class 3 indication was don't operate to prevent sudden cardiac death. Well, presumably that's what we're doing with those asymptomatic, very severe patients. So things have moved on. So just to touch on this issue of mean gradients, if people aren't familiar, so most of the predictors of clinical events will be based on the peak gradient from the peak velocity from 4v squared. A mean gradient, which the Americans and the Europeans use to also define severe aortic stenosis. The Americans greater than 40, the Europeans greater than 50, and that's severe AS. Proper severe aortic stenosis is basically the average gradient across that valve throughout systole. So the computer does it for you, and we just need to actually track around our program. So it's giving us a mean gradient of the instantaneous gradients over the ejection period. And they aren't quite synonymous, so trials have looked, and if you have a mean gradient of 40, you're sort of looking at a tighter valve than if you have a peak gradient of 64. So they're put in as if they're equal, but certainly the mean gradients of 40, 50 means really proper tight AS. So the role of exercise testing. Now, it's absolutely contraindicated to put a patient who is symptomatic with aortic stenosis on a treadmill, so it's really all about asymptomatic, and people worry about the hypotension on the treadmill, but actually the best predictor, adverse predictor, and this is John's work from Thomas's from a while back, the absolute predictor of symptom-free survival is actually dizziness on a treadmill. And when I send my patients aortic stenosis for an exercise test, I always watch them myself. I don't delegate it to a junior, because actually it's quite subtle and they're starting to go off, and that's the time they come off the treadmill. And clearly abnormal ECG, and I had a young lad recently who Mike operated a couple of weeks ago, 27, who went into left bundle on the treadmill, and clearly that is not a normal ECG response. So it has both a diagnostic and a prognostic use. We know that if you have an abnormal exercise test, you have a reduction in your event-free survival. And interestingly, about a third of patients in the trials who claim to be asymptomatic, actually when you put them on the treadmill, aren't. And of course, some of the older population will start to reduce what they can do to live within their means, as it were. In a meta-analysis, all the problems of meta-analysis, but within just a 1-year follow-up, there were no incidents of sudden cardiac death in patients who had a normal exercise test with severe AS, 5% though, sudden cardiac death in those with abnormal, and an adverse cardiac event in 2/3 of those with a normal test compared to a 1/5. The Europeans like exercise echoes. This will be a bike or on the end of an echo couch, scanning at the same time and just seeing if you can increase your mean gradient, and also pulmonary pressures, actually being able to invoke pulmonary hypertension on exercise has an adverse prognosis. And this is work looking at whether you had tight AS without pulmonary hypertension, and the worst people for follow-up, and this was only at 2 years, were those who had severe AS and who on exercise pushed their pulmonary pressures up. That's not within the American guidelines, but the Europeans rather like that. Okay, so what about this concept of low flow, low gradient, but preserved ejection fraction? So patients, as I've said, who appear to have a preserved ejection fraction, they have a small effective orifice area, and yet their mean gradient, their gradients are low. They are typically female, they typically have left ventricular hypertrophy, they will typically have a restrictive filling pattern. When you look at their diastolic flow, they have small cavities. And when we look on echo, they have reduced long axis function. So although their radial function is normal, their ejection fraction is normal, their long axis function is abnormal. And when you look on MRI, they have an increased fibrosis within that subendocardium. And they should be thought of as patients at a more advanced stage of ventricular disease. And therefore, waiting for them to develop symptoms and to try and push their velocity up above 4 meters per second is probably not appropriate, because they're not going to do it because they have an abnormal ventricle. They are tricky, and it's a whole sort of talk in itself. But even if we have standard AS, these were patients with gradients in their late 50s, so a different cohort, a more sort of standard cohort, if you have reduced stroke volume, it is a predictor of outcome post-surgery. And I think this is somewhere where we will continue to work on. And these were patients either with undergoing AVR and CABG, or those with poor reduced stroke volume was a predictor. Okay, natriuretic peptides. So they're in the European guidelines. They are a family of peptide hormones which are secreted from the heart in response to myocardial stretch. They're primarily coming from the ventricle. They predict poor prognosis in systolic and diastolic heart failure, and acute coronary syndromes if you've trashed a lot of muscle, and acute PE if you've got right heart strain. And we know that they are elevated in valve disease, where you've got the pressure of aortic stenosis, the volume overload of AR, and that mixture with aortic MR, and then mixture with aortic regurgitation. There are two in clinical use. The N-terminal pro-BMP, which has a much longer half-life and therefore is more affected by renal impairment, and the BMP, which is an active molecule which is cleaved from it. There's a range. There are different ranges for the two, and they can be either expressed in picomoles or picograms. And therefore, if you look at the trials of valve disease, some will use BMP, some pro-BMP, the levels will be different, and it's very awkward to see a sort of, there isn't a cutoff value. Okay, there isn't something that you'll say, well, if it's over X, that means I need to operate. But what it's very useful for is serial testing, or, as I've done recently in a young lad with aortic regurgitation whose ventricle's really a little bit on the edge. I've exercised him, he managed 18 METs, and his pro-BMP was normal, and I feel a bit more confident on sitting on him for another 6 months and then thinking again and looking again rather than diving in. So they can be useful, but there isn't a sort of cut-off value. What about their issue with aortic stenosis? They're in the European guidelines. We know that a raised level of this, from the trials they've used mainly BMP, is an independent predictor of survival post after a diagnosis of aortic stenosis. And as you might expect, the higher the level goes with, the sort of worse the AS and the more symptomatic you are. Where I think they may be helpful is in patients who may be very borderline, a lot of comorbidity, who have low flow, low gradient aortic stenosis, who you can show on debutamine stress echo have mounted a response, they have contractile reserve, we're happy we've got the diagnosis right. In patients who had a raised BMP, they had more than double the mortality post-AVR than those who had a low BMP. And it may be that if you have a borderline patient and then you can also show the natriuretic peptides are high and they really are a little bit borderline, it may help potentially to go down as another sort of decision-making tool to go down potentially the role of TAVI, or to think about whether AVR is the most appropriate treatment. And what about TAVI? Well, it's one of the few areas we do have some randomized data on for the Americans, just so we've covered it. The patient should be assessed in a heart valve team. The Europeans, in their guidelines, state that it should only be performed in hospitals, have on-site cardiac surgery. That hasn't come in to the American guidelines. And a class 1 are patients who have a prohibitive surgical risk and also expected to survive post-TAVI by more than a year. So we shouldn't put them into some of these really desperate cases that we see. They look at things like frailty index in addition. 2A would be those at high surgical risk, so not prohibitive, and a class 3 would be, if they've got so much comorbidity that we really shouldn't be, that would preclude any benefit of having their valve intervened on. Okay, so the last few minutes, aortic regurgitation, indications for an AVR. Class 1, if you are symptomatic with your severe AR, or you are asymptomatic but your ventricle is below 50%, or if you're undergoing cardiac surgery. So you'll notice within the class 1 there isn't anything about ventricular size. 2A, if you are asymptomatic and you have normal function, but you have a dilated ventricle, and within the new guidelines, there is an absence of anything to do with a diastolic measurement. So this is all about systolic, so an end systolic dimension of greater than 50 or 25 millimeters per meter squared, this really important thing of indexing. So we've jumped down in size, and say the Americans have dispensed with anything to do with diastole, so they're still in there for the Europeans. The other 2A would be if you have moderate aortic regurgitation, you're undergoing another cardiac investigation. So that was previously a 2B, which I find a little strange. But okay, the other 2B indication is if you are asymptomatic, you have a normal ventricle at rest, and you can show that you have progressive dilation. So every time we're echoing, things are on the move. Previously, they'd stipulated greater than 70 and 50, but here, this is where the end diastolic comes in, so it's a class 2B indication. And there's no class 3 for aortic regurgitation. So just finally, big bugbear of mine is this business of ventricular size. So when I was training, aortic regurgitation was all about the 55 rule. You referred when the EF went below 55 or the end systolic dimension was above 5.5 centimeters, and it was sort of da-da, and there was nothing much else about that. The guidelines, my end diastolic dimension, if I have a normal scan, shouldn't be above 5.3 centimeters. If you are a man, 5.9 is your cutoff. And so you can see that in the bad old days when it was the 55 rule, to expect me to get my end systolic dimension above what is even normal for my end diastolic, think one of you is going to operate and then my ventricle is going to get better, is a bit of a challenge. And the older work, so this is Elizabeth Clodda's work 20 years ago, showed that although the operative mortality between men and women for an AVR for aortic regurgitation was the same, women were on a very different trajectory and their outcome was less good, late deaths. And these, in part, were due to heart failure. And when they looked, we know that, apologies for the slides, these are scanned in because you don't get PowerPoint slides from 99, but we know that aortic regurgitation is associated with excess mortality above someone who doesn't have it. But if you look at the patients who have an end systolic dimension of greater than 25 millimeters per meter squared, so it's indexed the body surface area, that is a predictor of poor survival if you're conservatively managing aortic regurgitation. And one of the problems is that if we corrected for body surface area, we would provide an advantage for those patients like me who have a small body surface area, and that is 65% of women. And the probability of having an ejection fraction below 50% would be cut from around a half for a patient with small body surface area to a third if we just counted on correcting it. So it's a big thing of mine, but I think particularly, if you have a big bloke, you don't need to mind, but when you're seeing patients referred, hopefully all your echo labs do send with body surface area corrected measurements, but it's really important with AR because otherwise we can miss the boat and send them on. And in the older studies, the majority of women got their AVR on symptoms, where most men got it on size. And only 1 in 10 of the women were operated on for the LV on size because they never got there, just because they became symptomatic. So, any questions? Bit of a run-through tour of the guidelines.
I think we take, because the three talks are quite different, we take questions as we go along,
Okay.
so it's good.
Yeah.
Are there any questions from the audience? While you're thinking, I want to ask Rachel. One thing I was slightly disappointed about in the new guidelines is the information when you've got concomitant surgery. It sort of basically says if you've got moderate aortic stenosis or moderate aortic regurgitation and you're doing other cardiac surgery, you should change the valve. I think the difficult decisions are the sort of mild, moderate, borderline sort of things in the older patients. And they don't really help you in that case. We've sort of got a rule that if you're doing bypass grafting and at least one leaflet is calcified and you're approaching an area of 1.5 sort of centimeters and you think the patient's going to live at least 5 years, you should consider changing the valve. But with the advent of TAVI now, I hope the guidelines will give you something more specific for those mild aortic stenosis, mild AR, when you're already doing cardiac surgery, but they haven't really.
No. I mean, the usual, and also the teaching for sort of for aortic stenosis hasn't really changed at all. So if you're 3 meters per second, I mean, the guidelines would be above 3 meters per second, you should be thinking about changing the valve if you're going in for grafts. But I appreciate it's more complex than that because some of it's about things like rate of change. And then within those patients who might have, you know, round about 3, how many of those are this issue with low flow, low gradient, preserved ejection fraction? So I think we're understanding that it's much more complex, but I agree, all they've done is stuck moderate.
Yes,
in.
and that's quite
Yeah.
I may have missed it. Do you have a place for dobutamine stress?
Yes, so the place for dobutamine stress is in the cohort who have low flow, low gradient, impaired ventricular function. So they may be having an ejection fraction, it looks like 40%. Their mean and their peak gradients are below what we would count as severe, but their valve area is coming out as small. It's a big bugbear of mine because sometimes you have patients labelled as having impaired ventricle and they're generating a gradient of 80. That is a hypodynamic ventricle. It's more common in men than women. That is a ventricle screaming out to be relieved of its obstruction, and those don't need a dobutamine stress echo. They're mounting a high gradient. Their ventricle is okay. It's hypodynamic rather impaired. So this is the group where it's truly impaired with a low gradient. And the rationale for dobutamine stress echo, and as I say, normally within 10 minutes of doing the test, you've already got your answer, is that you can see that you get contractile reserve and the valve area stays the same, and yet you get a brisk increase in your gradient. So they're very rewarding to do.
Rachel, well done. You did make the guidelines exciting. Thank you. Quite a lot of patients with aortic stenosis have a degree of aortic regurgitation as well. And the guidelines are not very clear about mixed aortic valve disease. And yet a lot of the patients have got mixed aortic valve disease. How does that influence your decision making for surgery?
You're right, Tim. I mean, the guidelines don't broach at all, don't step into that area of mixed. I mean, the traditional teaching is 2 moderates sort of make a severe. And we do see patients who it is properly moderate AS and they have moderate AR and they will get into trouble and come in pulmonary edema. And the ones I really worry about is when you've got severe, and they're the ones I do treadmill and don't believe when they tell me they're asymptomatic. I think, I guess it's easier if they're coming for concomitant surgery. I think you'd have to watch them, and if they, I mean, most of the exercise data is for the under 70s, as you might expect, putting very elderly patients on the treadmill. But certainly in that younger group, I would exercise them yearly. I'd have a low threshold for things like natriuretic peptides just to try and help me, because some will coast along. There's nothing in either of the European or American guidelines that will help you per se. So I think it is very much a clinical business for assessment.
Into the Peptides?
Yeah.
Despite all the guidelines?
despite all the guidelines, as ever. Yeah. Dan?
How do we pick up the low flow, low gradient curve LD patients? Because they've got a low gradient, they don't respond to stress. So are we missing anything?
So I think they're the ones that we've brought to an MDT and everyone looks at them and they have a hypertrophied small ventricle and yet they've got a heavily calcified valve which doesn't seem to open, and then there's with a low gradient, and people sort of say, well, maybe we should repeat the echo, and we check and it's aligned, and everyone's tried with standalone as many places. And I think they've been out there. I think we've just sort of not known what to call them. So if on echo you can show that their stroke volume, which is easy to do, when it's indexed is below 35 mils per metre squared, that seems to be the group in whom we know that they have then prognostic benefit post AVR. But they're tricky because they're often those small cavity hearts. Again, the problem.
So I'm sure in a lot of MDTs, people are just saying, we'll echo them again.
Yeah, but it's not just echoing them again, it's getting the right echo. It's getting the sonographer to understand what we mean. So I think, yes, if you're with that sort of hypertrophied ventricle, but it's a heavily calcified valve that isn't opening, we really need to know the stroke volume. So I think it'll come in more as valve disease moves through, when we can see the importance of stroke volume, even on things like bypass surgery, and you can actually predict who's going to do less well just based on that. So I think it's an area we just haven't really understood, and we're starting to.
Rachel, I'll take the opportunity to ask again. In that group, you said we don't really understand. Can you go more on the stroke volume? We had a patient just anecdotally in the last few months where there was a lot of discussion whether to operate or not. And she was one of these little ladies with quite severe systemic hypertension as well, a long-standing atrial fibrillation, and there were multiple opinions.
Yeah.
In the end, I was elected to change her aortic valve, which I did. She survived. I don't think she's going to be any better. When I saw the leaflets, they were calcified, but it was one of those disappointing experiences of opening the aorta. And she got through her surgery. I haven't yet seen her in clinic, but I worry it wasn't really stabilized, and I worry she had sort of diastolic heart failure type symptoms, and I suspect we haven't done her good, I'm afraid.
I mean, it's a really heterogeneous group. They will, by definition, if they're LD, they'll have abnormal diastolic function, and it is really difficult to pick out which of the symptoms is truly due to the aortic stenosis. I don't think we've got a good handle on it. It's a relatively new concept, probably around 10 years.
I was looking through the guidelines for help, just
and it
to
doesn't,
find something that would have told us I shouldn't have operated on that lady, and there's nothing there.
And we know that the natriuretic peptides will be elevated, but equally if you've got diastolic heart failure and you're hypertensive, they'll be up in that too. Yeah. So it's a difficult area.
Can I just make a point on this situation? If I permit me to make a little comment. Here there is a heart which has got some obstruction over time. There is hypertension to go with it. So the left ventricle is hypertrophied. Now, there is a complication of the left ventricular hypertrophy itself because it will lose diastolic compliance. And it is like a bodybuilder building muscle, and he is very toned. He cannot relax. Now, if we just replace the valve, and these ladies tend to be, generally, these patients tend to be old ladies, smaller valve. So smaller valve will leave a patient prosthetics mismatch or some gradient behind. And we have not done anything to release this concentric ventricle. So should we treat them like Hawkins with massive myectomies so that there is some element of diastolic compliance relief and then something to enlarge? So just replacing their valve and thinking that we will solve the problem, which is beyond the valve, may not be the answer. So instead of thinking that there is no solution to the problem or these people should just suffer, maybe we should think differently. What do you think of that?
Well, in her case, the hypertrophy was concentric. It wasn't a bulge, and so she didn't have any evidence for reducing cavity size on the insides, unless they've got an outflow tract obstruction with a muscle valve.
We might get some help if we start looking at global afterload, and not just the valve. So, I mean, there are indices like valvular arterial impedance, which will give you a broader understanding of just exactly where the resistance is. Well, there's no kind of cohort data that I'm aware of that allows you to predict using those values, but developing that might start to give us some of the answers.
Tim?
As a group of surgeons, we need to think about this really carefully, because we need some clarity in this group. It's an increasingly frequent referred group. They're elderly, female over 80, so that's an increasing number in society. And their surgical mortality is likely to be higher because of age, but also because, as Rin said, they're likely just changing a valve. You know, the words you use there, squeezing a 21 in, actually they're looking at this group at really a root enlargement procedure if you're going to get in a decent sized valve. So clarity in the diagnosis, what's actually been diagnosed, and then what the best treatment of them is very difficult, because I think maybe we've all had that experience of opening the aorta going, oh, SH1T, are we doing the right? I mean, you know, replacing the aortic valve for a normal aortic valve, I mean, it's not a great place to be, is it?
Okay. Thank you very much.